Thank you everybody for joining us today. This webinar is brought to you by the National Center for Health and Public Housing. My name is Filipina Sandoval, and I am the Training and Technical Assistance Manager here at NCHPH. And I will be helping moderate today's webinar as well next to Dr. Kevin Lombardi. And Kevin, would you like to provide the introduction?
Hi, everyone. Dr. Kevin Lombardi, medical doctor and epidemiologist. I'm the manager of health research, policy, and advocacy at the National Center for Health and Public Housing. Happy to have you here today.
Thank you. So before we get started, these are just a few housekeeping items. Just a reminder to everybody that all participants are muted. Please make sure that you engage in the chat if you have any questions or any comments or any promising practices that you would like to share with us today. Also, raise your hand if you would like to unmute your line. This meeting is also being recorded, and the slides and recording link will be sent to you via email after today's session. Before we continue, this is just a little bit about our organization, the National Center for Health and Public Housing. The mission of the National Center for Health and Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. And CHPH is a project supported by the Health Resources and Services Administration and is a national training and technical assistance partner that is 100% financed by this grant. The information presented today are those of the author only. This is just some background information on health centers that are close to public housing. As of 2021 health center data, there are over 1,000 federally qualified health centers that serve to 30 million patients. 458 of those health centers are in or immediately accessible to public housing that serve to 5.7 million patients. And 108 that are public housing primary care grantees that serve to over 900,000 patients. All right. And now I'm going to pass it on to Dr. Kevin Lombardi.
Hi, everyone. So just a little bit about our demographic here. And when I'm talking about public housing and individuals that live in public housing and teaching on subjects related to them, I think defining the demographics and where it applies and where it doesn't apply is important. The individuals that live in public housing are demographically distinct from the general U.S. population. This isn't news. They're disproportionately Latinx, disproportionately African American, and disproportionately come from female-headed households. This is particularly important for this subject because there are a range of factors and outcomes that are linked fairly strongly to these factors, these demographic factors. So when we are talking about public housing, though, we're also talking about individuals who are HUD assisted, and these folks are all over the country. I'd want to be conservative in saying that most of you most definitely have them in your practice, and you most definitely see them. It's an important demographic, and it's a demographic that has important healthcare needs. So on to the next slide, please. So for our objectives today, so this is not a small subject. There is a lot of background knowledge that's foundational to this topic. So I'll be going over that as efficiently and high yield as I can. But I'll be taking an overview of sleep-related deaths, the demographic and social issues that are relevant to residents of public housing, and recent research and recommendations that can benefit program management. Finally, we'll be engaging in an emergent issues discussion on a particular subject that I think is low-hanging fruit for improving performance of your clinicians, yourself, and your health center. But to go specific in the learning objectives, we'll be presenting an epidemiological overview of sleep-related injuries, looking at the disproportionate impact of these sleep-related deaths on infants and marginalized groups, present the latest research and resources related to sleep-related deaths, and review the key interventions that can be used to manage the risk of these in your community. Next, please. And next, so section 1, we'll go on to the content background. We had a lecture on this a couple weeks ago, Fide. Next slide, please. And so do you remember anything about SIDS and sort of what SIDS is?
SIDS is basically a term or sudden unexpected infant death.
Mm-hmm.
It's a term used to describe any sudden and unexpected death, whether explained or unexplained or occurring during infancy.
Yeah, so it's of exclusion. It's a diagnosis of exclusion. There's a difference between SUIDS and SIDS. And SUIDS is when there are certain identified causes. So these are different ICD codes, and that's relevant to the research. But when we're talking about SIDS, for the purposes of this presentation, when I say SIDS, I'm referring to both of them. So, as you mentioned, it's used to describe any sudden and unexpected death, whether explained or unexplained, occurring during infancy, specifically the first 6 months. SIDS is a really complicated phenomenon. In case investigations, there can be a variety of causes: suffocation, asphyxia, entrapment, infection, ingestions, metabolic diseases. These are all just the list of things, of just some of them. So it's important to sort of set a model of how the body does this and why it happens, and plug that into the public health perspective of this. So if we could go to the next slide, please. And the best way I have to explain this is really the triple risk model. SIDS is a complicated phenomenon. With the lay people are given health information in a way that often makes them think that things are very cause and effect. And for those of us who practice clinically and have training in this, we know that that's often not the case. And where the challenge can be is explaining that. And the best way to do that is to really understanding and having a good foundational model in your own mind. So regarding SIDS, the triple risk model helps to conceptualize this. And essentially, it's a risk model. So every infant is at risk of experiencing SIDS. But for those who have had specific issues in their critical development period in utero development, specifically, there are some really high yield ones, like cardiovascular issues, maldevelopments. Exposure to cigarette smoke is a really big one because it impacts the neural development in different parts of the brain, trigeminal nerves as well. And it basically makes infants less sensitive to hypoxia. So they don't respond to hypoxia the way that one typically would. And if Fide, I were to ask you to hold your breath, you wouldn't be able to go very long. And the reason is you would feel this incredible urge to take a breath. And these are reflexes that are very deeply ingrained, but especially preterm infants or those who have had issues in utero, they don't have it yet as developed as we do. So they are vulnerable. And these things might seem small, but these are new humans. They are very tiny and they are physiologically still developing. So if you have issues during the critical development period, you can understand that as being a risk. But when you also have other issues, like a vulnerable infant, one that has a preterm birth or has an infection or a fever, these raise risk as well. And when you have other stressors, such as bad positioning or overheating, head covering blankets that cause asphyxia, and so forth, when you have you can think of these as all different risks that contribute to SIDS. And in order to really understand it, we need to understand that those things work together and could sort of conspire to make this more likely. And for me, when I'm thinking of program interventions of way to manage this, and importantly, how to communicate it to patients, that's a foundational understanding for me. On some of the bigger issues here, let's see if I missed anything. No, we can go to the next one. Thank you. Okay. Fide, you've seen this graph once before, I think. Can you sort of tell me what your impressions are of it? And this is epidemiology of safe sleep. It's deaths per 100,000 on the left axis and years on the bottom axis. And we're looking at 1990 to close to the present.
Yes, so definitely. I think from here, what we can see in the trends is that for especially for combined SUID death rates, you can see how it has been declining since 1990 up to 2015.
Mm-hmm.
And also the same thing applies to the rate of sudden infant death syndrome, which the decline is much lower compared to the one in the yellow line.
Mm-hmm.
And if we move on to unknown causes or accidental suffocation and strangulation in bed, those trends have increased slightly as we have moved on in the years since 1990 to 2015.
Okay, so like let's take this and sort of pull this apart a little bit and apply it to our subject. The good thing is over the long term, we've seen a decrease in combined SID deaths. But that's been a stubborn decrease. We saw a very severe decrease in the early 1990s, and then things have stabilized and continue to go down slowly. And there are some very real reasons for that. In 1992, the first recommendations from the American Academy of Pediatrics for putting infants prone or on their back for sleeping 100% of the time was drafted, and there was extensive policies to make sure that this was translated into the examination room. Now, since then, we've gotten better, but there is, if we look at the numbers of SIDS deaths that we're continuing to see, there are still a lot of places for improvement, and there are some, from a programmatic standpoint, from a health center, there's a lot of low-hanging fruit that can help protect your communities further. Next slide, please. And just a little bit on the anatomy of safe sleep. And Fide, I think I walked through you before, but can you look at the first, the infant to the left, the one that's prone, and sorry, the one that's supine, and the one that's prone on the right, and then sort of tell me how you think that would affect the airway anatomy there.
Yeah, no, definitely. I think when we compare both images, in the first one to the left, you can see how the airway is not being obstructed. Based on the position of the baby. And then on the second image to the right, which is the prone position, you can see how the baby does have the airway obstructed on the bed.
Now, you can kind of understand this if for anyone who's held a baby before, but these are not rigid people. They're just because of their level of development and how developed their trachea is, their esophagus is, their lungs are, their airway in general, it is going to be a little more flexible. So they respond more to distribution of weight than someone who would be older. And what you can see here is the image doesn't do justice to the amount of pressure and how that would affect the airway, but you have a more open airway when you have the infant on their back. And essentially, these are the recommendations that led to those changes in 1992. So, and since then. So next slide, please. Yeah, so one after that. So to discuss the disparities in SIDS deaths, there are significant disparities in these conditions experienced throughout the U.S. So to look at this graph, just to break down the acronyms here, the first to the left refers to American Indian and Alaskan Native. These are U.S. Census categories. The second, non-Hispanic Black. The third, non-Hispanic White. And then Hispanic and Asian Pacific Islanders. And what you notice is that there's a significant disparity between different racial groups. Rates of sleep-related deaths, like other causes of infant mortality, have notable and persistent racial and ethnic disparities. And this reflects a broader racial and ethnic social inequalities. And these are things that shouldn't come as a surprise to anyone, but I know that when you know it and when you see it on the graph, it sometimes can hit a little differently. Mortality rates for non-Hispanic, Black, and American Alaska Indian natives have also shown a slower decrease over the years as well. So cultural, behavioral, and economic factors play a role here. So differences in prevalence of supine positioning and other sort of sleep environmental conditions like presence of blankets and so forth are main contributors, believed to be main contributors to this. Next, please. Oh, and that's just a repeat, so the one after that. Yeah, and these are the CDC data, the infant mortality rate, and I wanted to get this here just to show how really large these disparities are. We're seeing the infant mortality rate is about 4 times as much for non-Hispanic Black related to non-Hispanic white ratio. And I mean, these are very low-hanging fruits from a structural standpoint. And if you can go to the next slide. If we look at the leading causes of those mortality, mortality, and you look at the next after that, the columns to kind of see the disparity difference here. And what you see is that sudden infant death syndrome is an issue for all demographic categories, but we're seeing it as particularly an issue for non-Hispanic Black individuals. Next slide, please. In housing-specific sleep rates for public housing. So, Fide, you're aware of the disparities of individuals who tend to live in public housing, that they're disproportionately from low-income households, that they're disproportionately in multi-generational households or single mothers. Considering this, some of the housing-specific sleep risks for public housing, can you think of any?
Yes, I think definitely the first one that comes into my head would be exposure to any kind of substances such as cigarette smoke or lead, especially if they live in older buildings. That could be something that can put the baby's life at risk.
So, some of the big things, and if we consider the built environment, this is a clinical phenomenon that requires us to conceptualize what the built environment is and the unique challenges that patients have when they're at home. And if you can imagine just the sleep recommendations and what the big ones are, that a baby have a flat, firm surface to sleep on, that they're in the supine position, non-prone position all the time, and that they not be bundled up or have things in the crib. Things like co-sleeping are not recommended unless there is a specific platform for the baby that's separate. And cigarette smoke, as we know, isn't recommended that infants be exposed to any of it at all. So when you consider the makeup of the households that tend to live in public housing and HUD-assisted adults as well, and what the data tells us about them, they experience these things at a much greater rate than the rest of the population. And from a programmatic standpoint, that information is valuable because it's low-hanging fruit. When we have individuals that don't have access to, say, the proper built environment, that's one thing. But if they also don't have access to the proper tools that facilitate these recommendations, that's another thing. So if there are programs in your community that give parents access to either used or funding for cribs, appropriate materials to make sure their baby sleeps in the appropriate way, and or education resources and so forth. These are things to keep in mind when you're in the examination room or you're designing programs. Next slide, please. And next after that. Okay, so we're approaching the halfway here, so I wanted to have sort of a discussion about one of the major issues that I know I've experienced in the exam room, and that my colleagues and I discussed quite a bit, and it's like how to communicate this appropriately, and where does cultural competency have a role in sort of discussing these things with patients, designing programs, and overall creating a framework that makes safe sleep a priority. When I was reading the new recommendations, and we'll go over them in a moment, one of the things that I always look at is the recommendations on overheating and head covering. And I know when I was a baby, my mother wrapped me up very closely. Like my mother's from the south of Italy, and that's how women took care of their babies there. There are ingrained cultural beliefs on disease transmission and so forth that women are all very pressured to make sure their babies, or at the time, were very bundled. And I know that my mother certainly struggled with the recommendations that she was giving from her pediatrician. And I think it points to the complexity of the immigrant experience in the exam room and the importance of using our communication skills and cultural competency to get around that and to navigate that as much as we can. I know that in clinical practice, both in the U.S. and abroad, these discussions change in every community that I'm in. So if I'm speaking to a public housing community or one that is not, or I'm speaking, understanding of their cultural environment and the sorts of things that people are dealing with at home are very valuable tools to understanding how that conversation should be had and how they're going to experience it on the other end. The added complexity here is when one of the areas of the low-hanging fruit for improving compliance for these recommendations is recent immigrants. We have one of the most diverse places imaginable. And for those of you who practice in urban areas, you're often not dealing with one or two immigrant groups that are in your practice, but you can be dealing with dozens and dozens. And considering the diversity of experiences that people have, it's a challenge in the exam room to be able to communicate to someone something when there are ingrained cultural practices. And I know for me, the important thing was, understanding, and from my mother's experience and the experience of women in my community and immigrants that I've met in practice, is understanding that those cultural practices are very personal. They're very deep-seated, and people believe they work, and they have reason to believe they work based on historical memories and so forth. I think that's an important thing to keep in mind. And that's a sort of a more difficult perspective to plug in sometimes because it's not directly actionable. It's a perspective, but I think it's a foundational perspective to having this conversation appropriately. Fide, just to have like our sort of short discussion on cultural competency and how it can be helpful in promoting sleep safe practices and sort of understanding the unique experiences of immigrants and understanding the diversity of their experiences. We had a conversation about this earlier, and you were talking about some of how this was done in your own community. Tell us a little bit about that.
Yeah, sure. So this is just a little bit background, some background about myself. I'm originally from Honduras, and I grew up over there up until when I was 11 years old, and then I came here. But from a personal perspective, and based on my experiences also with my little brother, when he was about 3 months old, I did notice that a lot of the practices that are done with like keeping him safe at the time is very different than what I have noticed here. Mostly, and I think a lot of that had to do with like what you mentioned earlier, the built environment that we had at the time,
Mm-hmm.
and also just what at the time my mom knew about taking care of my little brother, which was, as long as like they have like a safe, what they consider to be a safe place to sleep, which is at the time was on the bed, that was fine.
Mm-hmm.
But then, after looking at like these like new, more updated recommendations, I can see how that would be something totally different.
Yeah. So, and just to sort of adapt that to the clinical experience, these cultural practices are very, very deep-seated, and they're because they work, and they worked for people with what they had in their experiences.
Mm-hmm.
And when I'm having challenges explaining something to someone from a different cultural background in a clinical context, it's often helpful to reflect on those. considering this specifically, when you talk about the things that your mother did, and we look at what the data tells us, is that co-sleeping in particular is a very resilient practice. It's very difficult to convince people not to co-sleep, and with that, when they've made that decision to do that. And co-sleeping is a cultural practice that's used all over the world. There are millions and millions of people who are doing this as we speak. But what we know is that the recommendations are it increases your risk of SIDS. So how do we respectfully have that communication with someone that those are the recommendations, and how do we respectfully navigate those? And the reality with these ones is, with very personal and very deeply seated cultural practices, it's difficult to get to 100%. And I think the importance is if you think of it as sort of an effectiveness ratio, if you're integrating cultural competency and understanding into the workflow of how this is addressed, then it's going to increase the likelihood of success. And the discussions about sleeping and sleep recommendations, where these are happening, are important. For those of you, if we have any physicians in the crowd, or those who practice clinically on a shift base, then you're seeing patients for a very limited amount of time, and we are increasingly being told to do more things in that very limited amount of time. So these are things that sometimes, going through the recommendations with the length that it requires for someone from a different cultural or linguistic background, the clinician just does not have that time, and it's unrealistic to expect them to be able to do this as much as we would like them to do it. That being said, involving things like community health workers or social workers into the supply chain of providing this service is very helpful, and the programmatic research supports that. In particular, there's been data and studies that have looked at community health workers and their ability to communicate these topics effectively and to impart to cause clinical change and behavior change. And what we know is that it's effective. So it also, the important thing about that is it also takes a lot of pressure off of the exam room communications themselves. When a physician starts something with a questionnaire that has answers on it, it allows them to target that conversation. And targeting that conversation allows for efficiency and a better workflow. So this is one of those things that, in my opinion, improves both the experience of the patient and the clinician, is including the screening, which we'll get to in a moment. Next slide, please. So the recommendations for safe sleep were updated last year by the American Academy of Pediatrics. And I just want to go through some of the level A recommendations, some of the new ones, and some of the updates. Here is the link is here on all of my slides. I have a link for report. It'll be directly to the whatever resource is there. Some of these are really good. So Fide, do we send the slides out at the end?
Yes. Yeah, actually, I was just replying to one of our participants that we're going to send out the slides with all the links included.
Okay, super. So if you follow this one, you'll find the evidence base for all of the new recommendations and what all the new recommendations are. For those of you who haven't done a review of your existing protocols to integrate them where needed, maybe something to consider. And for those of you who aren't seeing clinicians who aren't clinicians, who are not seeing patients directly, I think this is something good to keep yourself up on as far as what the recommendations are and how they've changed. Some of the important ones, and we've discussed these lightly in other material, but back sleep for every sleep 100% of the time. And this can be a difficult one to sell, and because of the pragmatic decisions that parents often make with their sleeping arrangements. The use of a flat, non-inclined surface. So as you can imagine, when you have a baby that's sleeping on a very soft or foldable surface, they can fold. And the surface folds, the baby folds with it. And when the baby folds, their airway folds. And what we know is that when airways are folded, that the air can't go through them as efficiently. This is another risk factor to SIDS, and that's why the recommendation is as such. There's recommendation of feeding human milk as opposed to alternatives And that's data driven. There's evidence that those who breastfeed are more resilient to SIDS. So it's recommended that the baby be in the room and that they be kept away from soft objects such as pillows, toys, blankets, and so forth. These are all an obstruction risk. So if you have a baby that moves or something else that moves and it can move around their airway, it's potentially going to stop them, compromise their breathing, and it represents a distinct and different risk. And this is the one that often needs to be discussed directly by parents, because infants can get very tied, or parents can sometimes get very tied to the toys that they put in with their infants. So this can be a somewhat personal subject. And things that haven't changed. Avoiding overheating and head covering, avoiding the use of alcohol, marijuana, and opioids completely, and the immunization recommendations. So we know that that infection is a risk to SIDS. We also know that at times when when infants get vaccinations, they can have short-term fevers. We also know that vaccinations do not cause SIDS. There have been consistent results from large studies that have showed that vaccines do not cause SIDS. This is an important thing to state, even if it doesn't come up naturally in a conversation with the patient, because I think there are some pretty entrenched beliefs about these things that are very stubborn. So making sure that they know that SIDS and vaccines are not connected, and that they recommend that their infant get their vaccines according to schedule, we are covered. Next, please. Next slide, please. And these are just the details, some of the recommendations. The level B and C recommendations are, there's nothing really of particular weight here or has changed, but if you link to the summary recommendations, you can see all of them, and specifically the evidence behind them as well. And next, please. So to have did we miss screening tools?
Oh, there you go.
Now to discuss screening tools. Screening tools are a subject that is much more complex than just showing the tool and saying go use the tool. It's an issue of use, it's an issue of integration, and it's an issue of follow through. So when I'm talking about screening tools, I'd like to ask all of you to sort of think about how screening tools are used in your practice and how they're used at your health center altogether. Because it shows a framework of how things can realistically be done, and if there need to be changes. But in general, from the perspective of both management and in the exam room, screening tools, they help to improve compliance, but they're also really important tools for a conversation. And this is one of those tools that, in particular, I think targets the conversation in a way that's efficient and realistic for what we need to deal with in the exam room. So BIS-QR, and if you follow the link, you can sort of head to a printable version. But BIS-QR goes over a variety of questions that are straight out of the recommendations that I just reviewed. They ask about the makeup of the family, who sleeps with who, the sleeping position of the infant, the sleeping arrangement of the infant, if there are any obstacles at all when the infant sleeps. It gives you essentially a good picture of what the built environment is. And the challenge in the exam room is, what's the information outside of the exam room? Because you only have one person reporting to you usually, and it's the parent or the patient. So this is a really important one for structuring the conversation. there are a lot of recommendations here to go over. There's a lot of things, there's a lot of compliance to stick to when you have a baby. And this can be very overwhelming to patients. And what I like about this tool is by looking over just plain and simple what you have and what you don't have in the built environment and what risks are there and what risks are not, it allows you to take both an epidemiological and clinical perspective and to focus on the conversation on the areas that are the most high yield. For example, if the tool were to show you that the patient, the infant was sleeping in the bed with the parent, and that was the normal sleeping arrangement. Well, that's the place where the clinician would be able to focus their public health education and their conversations. How I would recommend these be used is to integrate them into your preclinical and clinical workflow. In my experience in managing screening and managing clinical programs, the focus is to sort of take the pressure off of the clinician as much as possible while still allowing the physician to practice their clinical discretion and have all the data that they need. And to not have the screening include any education that necessarily needs to be done by the physician, but to instead support it. As far as putting it into the supply chain of the preclinical workflow, a place where I would recommend is either a social worker or community health worker beforehand. For those who have not received, say, a standardized screening and education on this, it would be very easy, and I would recommend, and there have been programs that have done this in the past, by the way, but taking a community health worker or an ancillary staff member who is trained and have them be able to go through the questionnaire and do basic education and give materials to the patient. That allows conversations to happen about these things, and those conversations is where the patient often makes the connection that a behavior change should or should not happen. Those are timely conversations sometimes. And considering the gravity of this issue, if there is space for community health workers or social workers to be doing this, it's a good thing for them to do. It's also great for rapport building and building relationships with these patients as well, because you're interacting with them in a deep and personal thing at a very important time of their life. This is where rapport really matters. When you're building rapport in this time of folks' lives, because to be frank, if you put yourself in the position of the patient and they have a bad experience with their infant, it's going to be a really bad experience for them because just of the emotional involvement they have with this part of their life. So it's really important to make sure that you're communicating that these are important things and you're communicating them appropriately. I think this gives the framework to be able to do that. So if you follow the link, you can head straight to the screening tool. Do you have anything else to go over there? Because we got through this a little quicker than I imagined.
No, not at this moment, but we can open up the chat and see if we have any participants that would like to share anything about their own screening tools, anything that they may be implementing.
So we'll field questions and comments related to this, and also if folks have questions and comments related to the cultural competency discussion we had as well. Mm-hmm. All right, Fide, you can head to your thing about the survey and so forth.
Okay. All right, this is just a quick reminder to everybody to please complete our post-evaluation survey. The information that you provide to us is going to help us greatly in improving our future webinars. So we'll be very grateful for that. And then also, please make sure that you visit our website if you would like to get more information about our weekly updates, more information on webinars, toolkits, publications, our interactive maps, training manuals, and any information that is related to fact sheets and our blogs. And this is also our contact information. If you have any other follow-up questions that you would like to send to us, please feel free to send us an email, either to me at fide@mgt.com or to Kevin Lombardi at kevin.lombardi@mgt.com.
Great. Thank you all for your time today and for your service to your community and your populations. Have a great week.
Thank you. Muchísimas gracias.